Hello, and welcome to the University of Washington Cardiometabolic Echo Session 10. I'm Nicole Earhart, one of the adult endocrinologists here at the University of Washington. Today, we're pleased to welcome Charles Landis, who's a hepatologist here at the University of Washington, to talk to us today about non-alcoholic fatty liver disease. As well, we have our panelists today who include Laura Montour, our obesity and family medicine doctor. We also have Allison Everett, who is our certified diabetes educator and nutritionist. And finally, we have another adult endocrinologist, Savitha Subramanian, who is also our lipid expert. So go ahead, Charles, take it away.
As you can see, a fairly generic talk, at least title, as related to fatty liver disease. We're going to be talking about screening, diagnosis, and treatment. I do currently receive some research funding from Pfizer and Lilly, but that's basically done, but I do have to put it up there. So we'll give a little bit of background about fatty liver disease, what it is, what causes it, at least our current understanding of these things. And you'll notice that in that background, I'll start intermittently referring to non-alcoholic fatty liver disease as metabolic associated fatty liver disease because we're sort of a push towards a name change, but you'll also notice that I go back and forth because I'm just much more comfortable and used to saying NASH or NAFLD. But who and how we might screen patients with MAFLD, treatment for MAFLD, and I'm going to focus on lifestyle modification, which ends up being a focus for lack of a lot of available treatments. I will also talk about available treatments and then some treatments that are in the pipeline. Hopefully I'm not too far out of my league with Dr. Montour here and Allison Everett. I'm going to be talking a bit about lifestyle and dietary changes. Feel free to correct me if they feel like I'm getting something wrong. The term non-alcoholic fatty liver disease was first coined in 1980 at the Mayo Clinic when there was a patient who happened to be the wife of the dean at the time who had some abnormalities in her liver tests, and a biopsy was performed that showed fatty infiltration of the liver, and the pathologist said this is alcohol-related liver disease. And of course, she was a teetotaler and didn't drink any alcohol and got quite offended. And that led to ultimately this unfolding into the first paper documenting the concept of fatty liver disease in the absence of alcohol intake, which was termed non-alcoholic fatty liver disease. Since that time, there's been a little bit of a push to change that name because it includes the word non and the word alcoholic and maybe associated with alcoholic liver disease, and patients may feel stigmatized. So there's been a push to change it to metabolic associated fatty liver disease. But I can tell you this has not been widely adopted. So you'll hear both terms, and you'll even hear both terms in this talk because I fall back on that. As I mentioned, the histopathology, if we were to do biopsy on patients with fatty liver disease, is almost indistinguishable from that of alcoholic liver disease. What we typically see is a combination of inflammation or infiltrates of inflammatory cells within the liver, which I'm pointing out as we go along. Steatosis, which on typical staining just looks like an empty space because the fat gets washed away from the liver during the processing, and that's what you're seeing, these empty spaces. And then really the hallmark is something called ballooning or balloon degeneration, which is these are large, ballooned, injured hepatocytes, which may be on their way to dying and leading to regeneration, and also leading to cytokine uptake and production from inflammatory processes, which can also lead to the pathophysiology. The way we like to think about is as substrate overload lipotoxic liver injury. So through energy intake, which can be in the form of glucose and fructose or other fatty meals, we can ultimately produce free fatty acids in the liver, whether they're coming from other tissues or are being converted to fatty acids metabolically. You can typically, in the context of diet and excess adipose tissue, increased liver-free fatty acids, which can be metabolized, burned by a mitochondrial beta oxidation, or repackaged in the form of triglyceride or VLDL, which can lead to hypertriglyceridemia. But you can overload this process and lead to overload of hepatic lipid deposition, which leads to steatosis, and the presence of lipotoxic lipids, which can lead to oxidative ER stress, mitochondrial dysfunction, and hepatocellular injury and inflammation. Over time, of course, this is the first we'll see, which leads to NASH, which is the inflammatory response to steatosis, fibrosis, which is the fibrotic response to the inflammation. And then because of increased levels of regeneration and fibrosis, there can be an increased risk for liver cancer, even in the absence of cirrhosis. We often think of fatty liver as a continuum, starting with a normal liver, and then due to environmental and metabolic and genetic risk factors leading to excess fat in the liver, which can also be at least augmented by and also exacerbate insulin sensitivity. Ultimately, we build up steatosis, which is just referred to commonly as NAFL or MAFL, which is essentially bland steatosis, where we have fat in the liver, but without those other features, which would be the ballooning, as I mentioned, or inflammation. But that can progress towards steatohepatitis, NASH or MASH, which has the features of steatohepatitis with the inflammation and with this balloon degeneration. And then, of course, over time, anywhere up to 50%, I think that's a high number, up to 25% of patients with advanced fibrosis and NASH can develop cirrhosis over time. And of course, that puts you at increased risk of 5% for HCC. And then half of those may need to go on to require a liver transplant. And there's about a 20% liver-related mortality. I will point out, though, that most people with fatty liver disease do not die of liver disease. They die of cardiovascular disease. So it's also a marker for that, and that's something that I think anybody taking care of patients with fatty liver disease should not lose sight of. MASH is the most rapidly increasing indication for liver transplant in the United States. If we look at the absolute rise, and these are listings for patients without liver cancer, but the absolute rise, you can see this green line since 2002. It's almost the most common indication for liver transplant right now, other than alcohol-related liver disease. Interestingly, we have seen a rise in alcohol-related liver disease. If we forward this since COVID-19, it probably would have jumped up higher. The relative rise, fatty liver disease, is very much the highest since then, compared to any other liver disease as an indication for liver transplant. Well, I'm going to start with a case just to weave in the presentation. So this is a patient that is a 51-year-old man who presents to clinic for routine follow-up. He has a history of diabetes, hypertension, and hyperlipidemia. He's currently taking lisinopril, metformin, simvastatin, and fenofibrate for management of his metabolic syndrome. He rarely drinks social alcohol. He works in the IT industry. That's, of course, relevant because it means he's relatively sedentary during the day. He has a family history of type 2 diabetes and coronary heart disease. His body mass index is 36, but he's otherwise benign physical exam. He could probably have a little better control of his diabetes, but otherwise he seems to have it relatively well controlled. So I think the question is whether or not you would screen this patient for fatty liver disease. I think certainly I would. What would you do to do that? Would you just simply order some liver tests? That's what most people do. Or would you order an ultrasound to check for steatosis? Hopefully I'll answer that question. But I would say that the answer to that question is both would be okay. What are our screening guidelines? I haven't been very specific until recently on who we should screen. The American Association for the Study of Liver Disease really had no algorithm or really specific recommendations for screening, at least in their last guideline, which was in 2018, only to say you should have vigilance in high-risk groups, those with obesity, diabetes, or metabolic syndrome. The European guidelines were maybe a little bit better. They actually did recommend screening in these high-risk groups. And they also recommended using some laboratory-based scoring systems to help stratify whether or not patients were at low risk or high risk. I'll talk more about that. And then, of course, referral to hepatology for those in the medium to high risk range. And then I would encourage you to take a look at the recent guidelines submitted through the Medical Association, which really I think are very good and more specific guidance to this topic. And they recommend to screen high-risk patients, which are those with obesity, metabolic syndrome, and or elevated liver tests, and all patients with diabetes should be screened. It should be on your radar for anybody with diabetes. They again recommend using something called the FIB-4 score, which is a score that uses AST, ALT, and platelet count to give a non-invasive risk assessment for degree of hepatic fibrosis. And then based on that, Essentially, those with indeterminate or high risk should have liver stiffness measurement, and then based on the liver stiffness measurement, that will determine whether or not you should refer to see a hepatologist for further investigation. I think this is helpful and gives us real guidance. I gave this talk to a group of internists about 6 months ago, and I was given a really hard time because the ASLD didn't recommend screening, and I was recommending screening. So what do we do for screening? Like I said, just liver tests and ultrasound are acceptable. There really is no perfect screening diagnostic test. We could use a combination of ALT and ultrasound, but it probably should be mentioned that liver tests can be normal in someone with fatty liver disease, and actually liver tests tend to normalize as fibrosis stage increases and as you head more towards cirrhosis. So you could easily miss some patients with advanced fibrosis if you're just getting liver tests. Better would be to use some of the scoring systems, which use ratios of liver tests to either platelet count or ratios of AST to ALT, which are going to work a little bit better of those. I still like the NAFLD fibrosis score, which was developed by the NIH. I use that as my scoring system, although the FIB-4 is much simpler, and it was recommended by this recent guideline that I mentioned. FibroSure, some of you may be familiar with. We used to use a lot in hepatitis C. It's a proprietary test you can order. I tend not to use it because no one has shown me that it's any better than either one of these scores, and it's quite expensive. It costs several $100s when you can just essentially FIB-4, all you use liver tests and a CBC. Liver elastography, we'll talk a bit more about. Probably not a screening test, but certainly important in staging fibrosis non-invasively. There's also something called a FAST score, which combines elastography and liver tests, which I sometimes use, although I would say that's not widely used. I use it in my clinic though. Then of course the gold standard is liver biopsy, but obviously not practical to biopsy nearly 30% of the general population to determine if they have that. This is my algorithm for using the NAFLD fibrosis score, which was developed by the NIH. You could use a similar approach with the cutoffs for the FIB-4 score. But essentially, the NAFLD fibrosis score includes AST, ALT, albumin, platelets, age, and the presence of diabetes or the absence of diabetes will affect the score. It's an awkward range because it goes into negative values and positive values, but you'll essentially get values that help almost nearly rule out the presence of advanced fibrosis. And so a low score is really helpful. It's just when you're in the indeterminate range, most of the time you need to do a follow-up test. But you can still exclude up to 25% of your patients from needing any further study with this test. The FIB-4 probably lacks specificity, or maybe that's why they wanted to use it, because essentially they're going to be, it would reduce the burden for further follow-up tests, I think. But none of these are perfect, but we work with what we have. And I would just point out that although we like these scores, like the NAFLD fibrosis score, because they're albeit an imperfect surrogate for what we find on liver biopsy, that's how these study scores were validated. They, in and of themselves, they actually predict survival. So a low risk score shows very good 25-year survival in patients, whereas indeterminate or high risk score, you see lower survival, much like what we see in patients who have been biopsied. Those with early or minimal fibrosis essentially follow those similar to controls with no fatty liver disease. Whereas as we go up in fibrosis stage, we see long-term mortality with those with F4, which is the equivalent of cirrhosis, having the lowest 20-year survival. That's why we focus so much on fibrosis and surrogate markers of fibrosis, because this is really the best and only predictor for survival long-term. This is why we typically like to target for therapies patients with advanced fibrosis, because the idea being we want to reverse that and improve mortality. Again, long-term studies haven't proven that we get to do that, but I think it makes sense. Now, as I mentioned, those with indeterminate or high risk for having fatty liver disease with fibrosis, the next step generally recommended is doing something called transient elastography. The trade name is scan. There are other methods. You may have access to a radiology department that has some software on their standard ultrasound machine that allow you to do that. Though that test has not been validated nearly as widely and tends to be less consistent in the findings compared to vibration-controlled elastography, which is what I'm showing you here. It measures the stiffness of the liver by essentially a mechanically induced vibration in the liver, which is measured the propagation of that mechanically induced wave through the liver. It's essentially like knocking on the liver. If you knock on something hard, it'll make a hard sound. If you knock on something soft, it'll make a soft sound. And it's the physics behind it really aren't that much more complicated. It's probably, in a sense, better than a biopsy in that it actually covers more liver area, but it does have some severe limitations. It doesn't work nearly as well in those patients with high BMI. It also tends to be affected by other liver diseases, including those with hepatitis, cholestasis, congestion from, say, heart failure, or potential liver lesions, which we don't get an image, so it's possible there's things that could be missed. So it's not perfect, but overall, it's probably the cheapest and easiest way to follow up and to screen for advanced fibrosis. It still often requires a liver biopsy to follow up very abnormal findings. But as I mentioned, it's an imperfect measure correlate to what findings on liver biopsy. Transient elastography also showed is correlated to survival as well. Those with low liver stiffness tend to have the same survival as those without liver disease or fatty liver disease. So we go back to our patient who we wanted to screen for NASH. So we went ahead and he got some liver tests, and lo and behold, he did have elevated liver enzymes. His platelet count was 190, which is within normal range. His NFS score was in the indeterminate range, and his FIB-4 score was also in the indeterminate range for any kind of advanced fibrosis. So he was referred to the liver clinic, where he went on to get a FibroScan, which showed a liver stiffness of 9.6 kilopascals. And that, when correlating to liver biopsy studies, correlates to somewhere between an F2 and an F3 fibrosis. So remember, F4 is cirrhosis, F0 is no fibrosis. I won't go into the FAST score, but it's again in this indeterminate range. So he actually went on to get a liver biopsy, and we can debate whether or not we needed to jump to do a liver biopsy or not, but he went on to get one, which ultimately showed F2 fibrosis, which correlates reasonably well with the FibroScan, although I'd say the FibroScan overestimated it. Nonetheless, I guess the next step is we've identified this patient with fatty liver disease and biopsy-proven steatohepatitis and intermediate fibrosis. So I guess what treatment should be offered? In general, we still focus on general measures for management. And I'm not going to talk about these too much, but of course we talk about abstaining from alcohol, limiting alcohol intake. You should always discuss alcohol intake in the context of someone with fatty liver disease, because it's really hard to determine if fatty liver disease is caused from alcohol intake if there's substantial amounts of alcohol present. Address other risk factors for cardiovascular disease, but the mainstay is going to be working towards weight loss, typically through lifestyle intervention. You can also talk about bariatric surgery. And then there are pharmacologic therapies, which we'll talk a bit more and have become more prominent now. The recent guidelines are actually advocating the use of GLP-1 inhibitors along with pioglitazone, which has been available for a long time. In those without diabetes, we use vitamin E. There isn't enough data to support in those without diabetes. Talk about weight loss a bit. Weight loss intervention works really well for fatty liver disease. This is really a one-of-a-kind study that was performed in Cuba, where patients were enrolled in a lifestyle intervention trial where they were followed very closely and asked to adhere to a low-fat, average protein diet with the goal of intake towards weight loss. And they were also asked to do some type of physical activity, a minimum of walking for 200 minutes per week. And they paired biopsies. They had a biopsy at the beginning of this intervention, and 1 year later, they did another one. Pretty striking that of the patients in this study, of those that lost greater than 10% of their body weight, 81% of them went on to have regression of their fatty liver disease, including fibrosis. This is striking, of course. I think the caveat is that they didn't have a lot of patients with advanced fibrosis. Then only 30% of the patients were able to lose more than 5% of their total. So again, if you're able to achieve their outcome, you did really well. Only a small proportion were able to achieve that outcome. I think it's still worthwhile because this is really good proof that this approach works. Bariatric surgery is also proof of principle, I think, that weight loss helps as well. It's probably the most effective treatment we have. This is a follow-up study from Lazuli from an original study that he started in, I think it was 2015, it was first published. It's a French cohort of patients that received bariatric surgery. And those, based on BMI loss after surgery, the greater the BMI loss, the greater degree of resolution of NASH. And so if you lost greater than 10 BMI points, 90% of those patients went on to essentially have resolution of fatty liver disease. Likewise, those who've had bariatric surgery even had fibrosis regression. You can see here the proportion of patients who had F0 fibrosis, zero amount of fibrosis on biopsy at 5 years, increased from about 5% at the beginning of pre-bariatric surgery to nearly 60% 5 years later. So it's really an effective treatment. Unfortunately, for various reasons, not available to everybody, but I do recommend it. Doubling back on what to do in terms of weight loss, mostly we're talking about dietary therapy, exercise, talk a little bit about pharmacologic, although I'm not going to talk about this too much. You already mentioned the benefits of surgical weight loss, but I'm not going to talk much about that. A couple things just to touch on when it comes to fatty liver disease. And this comes up sometimes, and I get this from patients: should I be eating less fat or should I be eating lower carbs? Ultimately, I don't tend to prescribe diets in that way as much, but to answer the question, there doesn't appear to be a large amount of data to support low fat versus low carb, other than there's a couple of studies that have been performed in fatty liver disease. One study compared low fat versus low carb diet and did find that there maybe the ALT reductions were greater in the lower carb diet compared to the low fat diet. What otherwise, when comparing these groups, we see similar reductions in weight, body fat, visceral fat, ALT, and intrahepatic lipids when they measured in these studies. Really not much difference. We tend to lean towards lower carb, but fat is important as well. Likewise, because as I mentioned, most people with fatty liver disease die of cardiovascular complications. I think there's reasons to maybe think about low carb versus low fat in that context. This is a meta-analysis of many studies comparing low carb versus low fat. And this is probably no surprise to the audience here, but low carb diets tend to be superior in metabolic syndrome components such as weight loss, HDL, triglycerides, and blood pressure, whereas low fat tends to do a little bit better lowering LDL and total cholesterol. I tailor this based on the patient and their particular situation. Before we talk about weight loss, I think it's always important to note that you can lose weight with any change in eating habit. It's really the adherence that matters. This is a very old study, but shows that really you can lose weight with any one of these diets so long as you're adherent to it. It's really the bottom line. With that in mind, I don't tend to favor using a prescribed diet for weight loss with prescribed amounts of lipid and carbohydrate. I tend to recommend the Mediterranean diet as a guideline because it has relatively balanced amounts of protein, lipid, and carbohydrate. There's lots of recipes and there's plenty of data supporting it as cardiometabolic healthy and NASH healthy. It seems to work ultimately just as well in the long run as a low carbohydrate diet. Also, there's haven't been a lot of direct studies looking at the Mediterranean diet in NAFLD, but this is one study just assessed hepatic steatosis quantitatively by ultrasound, comparing individuals on a 6-month observational Mediterranean diet. Of course, they were getting monthly nutrition counseling, which probably was the most important thing other than what was recommended. You can see that over half the patients at the beginning of the study had severe fatty infiltration of the liver, and only 99% at the end of 6 months. So that tends to be my approach, and that's my rationale for that. I usually have a couple of slides on exercise that compared intensive exercise regimens and changes in liver fat. None of them are that compelling because they're all really small studies. I came across this in the New York Times a few weeks ago. I just found it interesting because we really can't focus on eating habits alone, and exercise is really important. This was a study from the UK Biobank, which always presents really interesting results. This was over 300,000 subjects, and they scored their dietary habits, which I think is a pretty low bar. You get a point if you eat processed meat less than 2 times a week and red meat less than 5 times a week, which seems not that great. But the bottom line for this is you can see that With improved diet, there's reduction in overall mortality and cardiovascular disease mortality. And then with the amount of exercise or physical activity, you see an overall reduction in all-cause mortality. But you can't fully correct for a poor diet if you're exercising. And you need to and with a good diet alone, you still aren't doing as well as some of the patients who had a poor diet but were exercising and very physically active. So the point of that is to incorporate that, and that is a discussion that we have to have. We go back to our patient. This is the same patient, just to refresh our memory. We advise weight loss and healthy eating, and talk about the Mediterranean diet and physical activity. He goes on and he actually decided to use an on-lam app-based weight loss program. He actually, I think, paid for noon. He started walking 30 to 60 minutes 4 or 5 times a week, and he actually had lost 20 pounds and said he felt great. You can see his liver enzymes improved, and this is a great success story. Of course, as we talked about, it's keeping it off that's the challenge. And I always bring this up to patients, is that if we're going to try and lose weight, you should think about who's successful at losing weight. And this is from a study of successful weight loss maintainers, and they tend to maintain calorie restriction and more physical activity and less screen time. Even if we looked at cognitive responses to food, they tend to have higher dietary restraint as well. So I bring this that it's just an ongoing thing. If you stop now, you're likely going to gain weight. So you still have to continue to think about this. This is an actual study pertaining to NASH. This is a lot of text. The bottom line is patients who were seen in liver clinics and advised to lose weight, about 30% were ultimately achieved the equivalent of a greater than 5% weight reduction, but 20% all regained it. And predictors of regaining it were insurance status and number of provider encounters per year. So I do think having a follow-up for these things is important. It may seem like you're not really doing much. You're not prescribing a medication, you're just counseling or talking, but I do think it benefits, and this study would support that idea. Now he comes back 6 months later, and he'd stopped using the weight loss app because things got busy at work, and he's been walking less, and he's unfortunately put on a little bit more weight, gained back 15 pounds. His liver tests have gone back up. He asked if there's any medications we can do. So what are the indications for MAFLD pharmacotherapy? Well, the ASLD, limited to those with biopsy-proven NASH. The European recommendation is those with greater than stage 2 fibrosis or high risk for progression, which is often determined by biopsy. Then the recent ADA guideline, which doesn't have a fibrosis threshold, really highlights the importance of really optimizing management of cardiovascular disease, and does give specific recommendations for using specific agents for treatment. I'll touch on those right now. So for vitamin E, it's not recommended at this point in patients with fatty liver disease and diabetes. Pioglitazone is now, I'd say, more widely used. It wasn't adopted very wholeheartedly over the last few years because of, I think, just resistance and bias towards these medications. I do think in the last few years, at least, I've been prescribing more pioglitazone, and I think as a community, we're tending to use it a bit more in fatty liver disease. Metformin is acceptable for diabetes management, but doesn't work very well for fatty liver. Statins, again, not specifically for fatty liver, but there's no limitation on using them. Ursodiol is not recommended. Omega-3 fatty acids can be used, but not specifically for NASH. Obeticholic acid, for which is an FDA-approved medication, which actually had positive phase 3 results, but it's not recommended at this time. And the GLP-1s, there's no recommendation from the European or American guidelines, but the recent ADA guideline does recommend using GLP-1s in patients with type 2 diabetes or obesity and fatty liver disease. And GLP-2s just really needs further data, but is acceptable for use. There's no contraindication. This is the original data for vitamin E versus pioglitazone for placebo. I'll just point out no improvement in fibrosis, but reduction in all other histologic features of NASH in that original study from over 10 years ago. Subsequent meta-analysis has shown that there's maybe a marginal improvement in fibrosis for vitamin E, but a definite sustained improvement in other histologic parameters. Pioglitazone, now based on meta-analysis at least, favors reduction in fibrosis, and so it's one of the few agents we have that has been shown to reduce fibrosis in fatty liver disease. Some safety that I think would be worth just mentioning. There's some lingering concern about vitamin E, about possible all-cause mortality, not confirmed, though, in a recent meta-analysis. increased risk for hemorrhagic stroke, marginally increased risk for prostate cancer. And then pioglitazone, you're probably all familiar with the potential side effects of edema, weight gain, risk for CHF exacerbation, possibly osteoporosis, and possibly bladder cancer. And then I'll just jump to the new kid on the block, not for everyone here, but I think for the fatty liver community, which is the GLP-1s. There was a study for liraglutide a few years ago, which had very similar results to this most recent study for semaglutide in patients with NASH. This was a phase 2 study with about 150 patients who were randomized to placebo versus varying doses of semaglutide. This is 0.4 milligrams daily, which is not that helpful because we like to use the weekly dosing, but you can average up over the course of a week, showing that there was significant reduction in the inflammation and histologic features of NASH in those taking semaglutide at the highest dose. And there was no worsening of fibrosis. And I see that as much like I treat weight loss sometimes for patients. Lack of weight gain is still a success, just like lack of fibrosis progression should also be seen as a success, but that may not be to the bar that the FDA wants to see things, but I see it as a positive. On the other hand, there did not appear to be any improvement in fibrosis stage, and that was the lackluster finding. I still think these are positive results, and there's positive metabolic effects, and I think stabilizing someone at stage 2 fibrosis would certainly be better than having them progress. We talked a bit about semaglutide and pioglitazone as potential options. There have been a lot of failed studies in this arena in the past few years. Just to point out a few, obeticholic acid, which is a synthetic bile acid, it's a farsamate X receptor agonist. It actually had a phase 3 study published just about a year and a half ago with marginally positive results with improved fibrosis and features of NASH, but the FDA wasn't satisfied, so it's failed. They're submitting again soon. It's already approved for primary biliary cholangitis, so it is available, but no one's using it for that disease. These, I'm just going to run through. There's a series of negative studies here. I won't even mention them. Resveratrol is a very interesting liver-selective thyroid hormone receptor beta agonist, which actually positive phase 3 results recently and actually is submitted to the FDA recently, so I'm excited to see where this goes. Ranitol, which essentially reduces hepatic steatosis, is ongoing. And there was a phase 3 study for semaglutide, but I actually don't know what the status of that is right now.
Thank you, Charles. That was a great summary and initial discussion. There's some great questions that I wanted you to answer that came up in the chat. There was a question, if the scoring turns back low risk, how often do you recalculate it?
Yeah, good question. There aren't any guidelines on that, but the laboratory-based scoring, I usually do annually. It probably could be every 1 to 2 years, depending on the status of the patient. If they're otherwise stable, you're stretching things out. But I usually do annually. Then the question, in terms of FibroScan, if we're going to follow that up, which sometimes I'll do with someone with an indeterminate level of FibroScan, I'll actually give a trial of lifestyle management or treatment and then repeat the FibroScan. I'll do that maybe short term, 6 to 12 months. But in general, I do a FibroScan every 3 to 5 years.
Great, thank you. And then there was actually a specific patient question. This was a patient whose BMI is very high at 63, and then the FIT4 score was low, and the NFS score was indeterminate. Because the FibroScan is going to be difficult with such an elevated BMI, does this person merit referral? A lot of these things are weight management. So for this specific patient, and then in general, when is it appropriate to refer and when is it appropriate for the primary care physician to address and work with the disease?
Yeah, good question. And that's a particularly challenging situation, patients with very high BMI. The one thing that you might want to do is remember that liver tests can often normalize in the context of cirrhosis, so you might not be completely reassured by the liver test, but if there are features of cirrhosis, let's say you have some degree of thrombocytopenia, or you have an ultrasound or some cross-sectional imaging that may show splenomegaly or signs of portal hypertension, that would be definitely someone you'd want to refer, even though there's probably not much in the way of help that we could give you in treatment, and we probably wouldn't do a biopsy, but I think it would help risk stratify them. They would probably need liver cancer screening, potentially an endoscopy, those kinds of things. Now, let's say you don't see those features. Obviously, it would be important to work towards weight loss. If you're going to be working towards bariatric surgery, sometimes you might want to consider doing a liver biopsy if you have a concern for more advanced fibrosis or early stage cirrhosis, because the surgeons might want to know about that if there's any sign of portal hypertension. So it's a tough one. The other thing that sometimes comes up is using MR elastography. Someone with a BMI of 63 might have a hard time doing even that. That is a really challenging situation. You're left with uncertainty short of doing a biopsy. If you have high suspicion, I think it's not unreasonable to do biopsy. And I have done biopsies in patients with those high BMIs. I typically will do a transjunctional biopsy.
Is there anyone that you would do an MRI for imaging, or do you feel like there's little utility in it? You just maybe said this exceptional person, but
I think there are some rare situations where about 5% of the time we just can't get a good reading on ultrasound-based elastography. And it may be reasonable to do that in lieu of someone we couldn't get a good reading on for ultrasound-based elastography. So those patients who tend to have it on the higher BMI side.
and then we have so many patients that have so many comorbidities. We are thinking about our diabetes medications outside of glycemic management. It is something that I definitely am starting the discussion about, although we're waiting to see that change in fibrosis, because my understanding of the GLP-1s is that you see some improvement of the NASH, you see stabilization of the fibrosis, but we haven't seen the gold standard of improved fibrosis. That's only been seen in the pioglitazone. And we use that more, but in a select population because of the risk benefit of the drugs. What is your thoughts about the sodium glucose cotransporter inhibitors? Because I don't know of any prospective studies that are going to be looking at them. And yet there was some positive results from the imaging, and then obviously AST, ALT, which you see in metformin and then didn't turn out. So what do you think of those?
And you're right, there aren't really a lot of good prospective studies, but I think there's a lot of anecdotal evidence, and there are some smaller studies that show some benefit. I didn't show those here, but there really isn't enough to make a recommendation. I don't think I would recommend using them in the absence of diabetes, much like the heart failure folks are starting to use them in the absence of diabetes. I wouldn't recommend that for someone with fatty liver disease. I just don't think there's the data for that. But in someone who has diabetes and fatty liver disease, I certainly would not dissuade you from this. That's where I would leave it.
I always think about it as just being the advocate for the patient. If they have other comorbidities that indicate the disease and they also are struggling with fatty liver disease, it's another reason to advocate for a patient for these potential beneficial drugs.
And remember, only a small proportion of the patients with fatty liver disease are going to go on to develop advanced fibrosis and cirrhosis. But a large proportion are going to go on to develop cardiovascular mortality. And the recent guidelines, what I liked about them so much was that they really focused on that approach, this sort of broader approach of managing the entire patient in the context of whatever specific problem.
Yeah, and a great point. I'm going to go ahead and ask Vina to share the case and take it away.
My case is about a new patient who came to see me about 2 weeks ago. Was his first visit. He was a add-on for a same-day appointment for high blood pressure, new patient to me, 51-year-old Hispanic male. He does not have PCP. His last visit was about 3 years ago. He said he had a diabetic screening and didn't have any history of high blood pressure. He was seen the day prior for dental work. He needed some sort of dental procedures, and his blood pressure was very high. So they told him to go see a doctor for management of his blood pressure. His first visit with me on the 19th of July, his blood pressure was 192 over 122. But he did not have any other symptoms. He did not have any chest pain, didn't have any signs of headaches or any other signs of organ damage. So I did not send him to the emergency room. I started him on lisinopril, 40 milligrams, and chlorthalidone, 25 milligrams. I told him to start taking the chlorthalidone that night. This was actually my last patient of the day, and I wasn't able to get any labs because the lab was closed by the time I ended up seeing him. I told him to start taking chlorthalidone that night, and then the next day, and then in 2 days, take the chlorthalidone and lisinopril to not lower his blood pressure suddenly. He was going to come the next day and get labs, and I made an appointment for him 4 days later to check up on his blood pressure. He did mention that he was told in the past that he had fatty liver and that his cholesterol was elevated. He didn't have any medications or anything in the past. So when he came for his test the next day, his lab results were diagnostic for type 2 diabetes with an A1C of 10.6 and a random glucose on the CMP of 298. And his lipids showed decreased HDL, elevated triglycerides, elevated blood pressure. By the second visit, it had improved to 149 over 105. And I did an EKG and showed sinus rhythm without any ST elevation or abnormalities. At the second visit, I added lodipine, 10 milligram once a day for his hypertension management. I made an appointment in 1 week for his hypertension follow-up for all the things that go with type 2 diabetes means. This is the comorbidities or complications that arise from type 2 diabetes and goals of management, the goals of A1C control and glucose monitoring. He was started on metformin, 1,000 milligrams. He was going to take it once a day for about a week and then titrate up to twice a day. And lipid 10 milligram also once a day for about a week and then twice a day after that. I sent all the glucose monitoring supplies. Because he reported the history of elevated LFTs and fatty liver in the past, and he had elevated LFTs on the labs that we had done that week, we got an acute hepatitis panel, checked him for hepatitis B, surface antibody check for immunity, and also a referral for right upper quadrant ultrasound to check for fatty liver. He was started on high intensity statin, also because of his diabetes status and normal lipids. He also met with a care coordinator during that second visit with our health educator. And there were brief visits to discuss brief lifestyle interventions like diet, exercise, decreasing cholesterol intake, decreasing carb intake, and not very in-depth educations, and also just brief glucose monitoring education. The reason I chose this patient is because I have very similar cases. So I just wanted to get an idea of which patients actually need further treatment or need further evaluations for NASH. For his medical history, he was diagnosed with hypertension, onset type 2 diabetes, elevated LFTs, and a history of fatty liver that he reports. The medications, he was started on lisinopril 40 milligram once a day, orthalidone 25 milligram once a day, amlodipine 10 milligram once daily, metformin 1,000. He was going to titrate to twice a day use. Glipizide 10 milligram, also titrate up to twice a day use, and atorvastatin 40 milligram once a day. He did not have any drug allergies or prior medication use. He says that he does not have anyone in his family with any chronic medical conditions, including type 2 diabetes or heart disease. I did not verify what kind of job he did or his education level. He does not smoke, and he does drink about 2 beers a week. His BMI was almost 36. At the second visit, his blood pressure was 150 over 105. And the lab results you can see there. And his creatinine was within normal limits. I saw him yesterday, actually. So we did get a microalbumin yesterday, and that was normal. He's had a retina scan, which also showed no diabetic retinopathy. His blood pressure, though, did not improve much with the addition of the amlodipine 10 milligrams. It was 140 over 80. So the diastolic did improve, but it's still not at goal of less than 130 over 80 on maximum dose of 3 oral medications. Those are the results of his albumin and the AST ALT that was done 2 weeks ago. And I did get the results of the acute hepatitis panel, which was non-reactive for Hep A, Hep B, Hep C, but he was not immune to hepatitis B. So I did see him yesterday, and I also have the results of his upper quadrant ultrasound, which showed hepatic steatosis. So we did talk about that yesterday. Some of the updates from yesterday's visit was that I did change his calcium channel blocker to nifedipine because of his still uncontrolled hypertension on 3 oral medications. I'm sending him to do a sleep study and further evaluation with a nephrologist for resistant hypertension. In terms of diabetes, he has started checking his sugar. He was still taking the metformin and the glipizide once a day, but the GI upset was improving. And so he was going to start taking them twice a day. And he has an appointment for follow-up with me. He does have insurance and he is able to get around. He doesn't seem to have any those kinds of limitations to getting care. The one thing we had not discussed his eating habits because his visits are 15 minutes long, and I've had 3 visits with him where I've had to diagnose multiple new problems. So I've not been able to have a full discussion about his eating more in detail. And he has not had that visit with the nutritionist yet, but we have referred him to a nutritionist.
Awesome. Great presentation. And just kudos to you because we know how much you just did in 3 15-minute visits with 3 new diagnoses and supporting that patient, and as well trying to do medication and lifestyle management. So great job. I'm going to ask Charles, what would be your recommendations for next step from a hepatologist perspective? And then Savitha will do the case notes instead of a recap and more in-depth look at this patient. Go ahead, Charles.
Maybe I missed it when it scrolled by. Did you get a CBC as well? The reason I asked that is because I would want to get a platelet count to help stratify and to calculate a risk score, whether it be that NAFLD fibrosis score or FIB4 score. Then you can determine, I suspect he's going to be in the indeterminate, potentially even high risk range. So you may still want to consider referring for further testing. But with that said, I think in this case, there's a lot of things going on. And I think the instinct for the hepatologist is to say, well, we'll bring him here. I think in this case, with the A1C of 10 and a lot of work to do, I would get the CBC and do this risk stratification and see where you stand, and then work with the patient to try and improve some of these parameters, maybe even repeat these things 3 or 4 months down the road. Then make a decision about referral, because it's often a lot, right? This is someone who's just engaging for his healthcare, and then to send him off to a bunch of specialists may make it even more challenging. So that's the way I see it. It wouldn't be inappropriate to send him now, but I think I would start with getting a CBC, platelet count, calculating a FIB4 score, and then based on that, where do they stand? In the meantime, simultaneously work with him on the issues that he needs to work on right now. I wouldn't be opposed to using some of the agents that we typically advocate for in the context of diabetes. So if you needed to resort to using a GLP-1, you could plus or minus pioglitazone, depending on how you feel. I think I'd probably, in this case, I might start with GLP-1 if that's appropriate.
Makes complete sense. And this is a marathon disease, just like many of our chronic diseases like diabetes, not a sprint. Sometimes focusing on one issue to best support the patient and slowly adding things is the best avenue of approach, and holding off on that referral probably is very appropriate. Go ahead, Savitha, give us a case summary and let's talk a little bit more about this patient.
Yes, thanks, Nicole. Thank you, Charles. That was a good segue because that's going to be the gist of what I'm going to say, because you don't really need to do everything all at once in 15-minute appointments. It's a lot, especially when they show up as your last patient for the day after seeing 20 patients. So thank you for that case presentation. Just a quick summary of this patient. So this is a 51-year-old gentleman who has been newly diagnosed with a whole bunch of chronic diseases. Dr. Landis said just engaging in healthcare in a backwards way because he had his blood pressure checked in his dental office and then landed up in the clinic setting. New diagnosis been started recently on dual therapy with metformin and glipizide, also rapidly escalated to triple drug therapy for newly diagnosed hypertension. Thankfully, there hasn't been any microvascular complication that has been picked up so far. And he has elevated liver function tests that he's probably known about for at least 3 years is what it sounds like. No significant family history. And we heard that he is insured. I wasn't sure what kind of insurance he has.
I think he does have some sort of insurance. I don't think it was a state insurance. It was a private insurance.
Okay, so it's a private insurance. I don't think you shared his employment. You said you hadn't gotten to it, right?
Yeah, no, I don't know.
Okay. Yeah, you've done a lot in 3 visits. He's Hispanic heritage. He drinks a couple of alcoholic beverages a week, and most recent blood pressures, his weight, his BMI is shown over there, 36. See, a diagnosis was 10.6%. His random blood glucose was 298. You can see his lipid panel over there, mild triglyceridemia with a low HDL. His LDL, I'm assuming that is before you started on the atorvastatin, Alicia, is that?
Yeah, that was, and I'm not sure that's a fasting because he did come after work to get those labs. That was before any other diagnoses were done.
Okay, fantastic. Okay, so excellent. All right, let's break it down and see what's going on here. The diagnosis, I think, is pretty obvious with all the metabolic stuff going on. He likely has type 2 diabetes. And so therapy options, which we'll get to, is appropriate. And we won't really know what's going on with his blood sugars unless he tests. And as you go on, and his A1C, of course, you want to wait about 3 months before you see a change. As Dr. Landis mentioned, general goals in this gentleman, he's just engaging in care, and we are throwing so many new diagnoses at him. I think trust building, confidence in the provider, which it sounds like he's already well on the way in establishing with you, but it's a very important part to keep him engaged. Also, I'm going to call on Allison here, but an important part is ongoing education because he has a new diagnosis of diabetes. So Allison, do you want to chime in on what might be some things that you would cover as part of education for this gentleman who's just recently diagnosed with diabetes?
I understand at CMAR you have a registered dietitian and you also have a health educator. Is that correct?
Yeah, we do have them on our staff. They're not there all the time. We have a registered dietitian who is in our clinic 2 days a week, and she covers another clinic 3 days a week. She does do a lot of in-person or phone consults. She is booked out 3 months right now. The health educator and care coordinator are supposed to be more for like point of care, short, brief education when we have these patients.
Oh boy, so that's tough.
Allison, before you continue, to maybe give us an idea of what diabetes self-management education involves and how it might be done in a 15-minute visit when educators are booked out 3 months. That might be a good way to.
So
yeah,
for the provider,
yeah.
you mean?
Yeah.
Okay, well, I think Savitha's point, and as you have demonstrated already, building that trust relationship with the patient, finding out where they're at, asking open-ended questions. I know a lot of times in a short appointment, you don't have, you ask an open-ended question and you're afraid they're going to talk for 15 minutes, but the biggest low-hanging fruit, I think, in this situation is just even in a minute, take me through a typical day of what you eat. I know you don't have a lot of time. Maybe this would be in a follow-up visit because you've done all these other things in the earlier ones, but what do you eat? And then I always encourage providers to go back and ask, what do you have to drink at that meal? What do you have to drink between your meals? Because especially in the situation with a fatty liver, we know they say less than 20 grams of high fructose corn syrup. That's 1 can of soda pop. That can really make a big impact. Just getting an idea where they're at. Maybe it's not perfect, being open like you are, because I think so many patients are afraid of sharing how they really eat and just finding out where they are. I don't know what else I could do in 15 minutes.
It could be maybe 2 sessions.
I would get him on the schedule to try to get him with that health educator or on the 3-month, and try to do it on a day when they're seeing you. What we find often is that patients, if it's just coming to see the dietitian, they may not come to that appointment, but if they're seeing you either before or afterwards, and then leveraging that health educator to say, hey, could you do a nutrition history for me? And then if you have that trust relationship with the patient already established, maybe you can then do some coaching if that person's already done the heavy lifting for you. The other thing that, and I'll just end on this, is I ask the patients, every patient I see, even if they are living in their car, they have a smartphone. I ask them to take a picture using their smartphone of every meal they eat and every beverage they have for the day or two before they come into their appointment. And guess what? They do that. So that way you could get an idea very quickly, just scrolling through their photos, what their food and beverage intake is.
Thank you, Allison. That's a great start. To add to that, I would also, as part of that trust building, figure out what he does, what his home situation is, who else lives in his house, because diabetes, as you've heard over and over again, chronic disease, a huge part of it is the psychosocial history, because it's a family disease. Who does the cooking? What is his home life like? What is his employment? What does he do for food? Simple, there might be things you could quickly hit upon. What is health literacy? All those things give you the whole story of his life so you can tailor your treatment accordingly. So just some general thoughts there. And looking at the diabetes goals, this gentleman, he came in with an A1C of 10.6, and I didn't hear any symptomatic hyperglycemia. I didn't hear any catabolic symptoms, no weight loss, no increased polyuria, polydipsia. So I want you guys to keep that in mind. And just a quick picture here of the general decision cycle for how you make decisions for people with diabetes. It's a shared decision-making process. You assess the patient's characteristics, what are the things that impact. These are all things you do, but it's just pictorial representation of how. That's why you want to know what he does, what his home life is, who does the cooking, who does the groceries, what is his life like? Is he busy at work and forgets about things? This is a new diagnosis for him. You've already put him on so many medications. He has to be adherent, and you want success long term. So a shared decision-making process, agreeing on the plan, and then helping the patient implement it, because they come to see you for 15 minutes every so often. You see them for maybe 2 or 3 hours in a year. Everything else, they have to manage themselves. And that's why the self-management education and everything else is just like building a building. You start from the bottom up. You don't start from the top. So DSME is very important in shared decision-making. Treatment, this is the algorithm you've seen in a previous talk. I just want to point out metformin at the time of diagnosis is completely appropriate with lifestyle modification in people who are not symptomatic and not catabolic, even though their A1C is so high. So metformin monotherapy, you did the appropriate thing. I think it's fine, because maybe there are people thinking this person should have been started on insulin, but he has no catabolic symptoms. This is completely incidentally picked up. This happens all the time in primary care, as you guys all know. Even with just metformin monotherapy, you may be able to get him down nicely, 2% on the A1C. Maybe not, but again, if he was catabolic and he had severe hyperglycemia, as I've written over there, fasting glucose over 250, random glucose is always above 300, and there's catabolic symptoms, you are probably looking at insulin. But this gentleman did not present like that. And also, I want to remind you that these days, you can actually consider a medication independent of their A1C or their A1C target. And essentially, you would pick based on cardiac or renal status. Do they have heart failure, ASCVD, et cetera, et cetera. This is not typical for somebody who walks in, is newly diagnosed diabetes without any of these things. But if this gentleman had an MI maybe a few years ago, and this is new diagnosis afterwards, establishing care, you might think differently and initiate a different drug. And that drug would be going down the left of this pathway, but we're not going to go into those details. In this gentleman, after metformin, you started glipizide, which is not wrong, but if you want somebody with a BMI of 36, if you look at the algorithm to promote weight loss or to minimize weight gain, what's actually recommended is in the middle here, which is GLP-1 receptor agonist, or an SGLT2 inhibitor. So 2022, you want to think this is modern medication, modern treatment. While glipizide is fallen into the cost and access on the right side, that green box, as well as the TZDs or insulin, it would not be inappropriate to look at GLP-1 receptor agonists or an SGLT2 inhibitor in this case. That said, on people who have very high A1Cs, unless they've come down, adding an SGLT2 inhibitor when they're very hyperglycemic, these drugs will not work because they're not great glucose lowering drugs in general. A GLP-1 receptor agonist would not be a bad idea if it's covered on the insurance formulary. So I just want you to keep that in mind. Then the cardiometabolic goals, blood pressure, big part of this, a lot of the medications that he has been initiated are related to his hypertension. Quick reminder on blood pressure checks, make sure they're seated, back rested, legs not crossed. They've been resting for hopefully 5 minutes. They're not rushing in from traffic, especially if he's coming in, and make sure the feet are on the ground. So just basics of blood pressure checks, make sure the arm cuff is appropriate, and a reminder if he's able to get a machine at home to check at home. Also, I don't have a slide. Diet is also a big part of hypertension. He's already on 3 meds over sequentially. This might be a time to look at his sodium intake. DASH diets, time tested and proven for hypertension. So just keep that in mind. And antihypertensive therapy choice, as you've picked, if you have blood pressure that is over 160 over 100, you want to pick 2 medications, which is what I did. She picked an ACE inhibitor and chlorthalidone, so a thiazide diuretic, which is quite appropriate. Nocturnal dosing may be helpful in some people. Before I go to the triglyceridemia, I do want to mention, you've already got him on 3 meds. I would encourage, rather than push any further, because he's already in a safe zone, I'd probably just wait and see, maybe have him assess his sodium intake, then just wait it out for at least a month before you say, okay, he needs 4-drug therapy, because I think you said 140/80. So it's not too far off. Maybe just some lifestyle adjustments is all that he needs. And I don't think he is yet resistant hypertension. I'm curious to hear what other colleagues think, but I think you can wait it out on the 3 medications. It's only been 3 weeks, I think, since you've got him on the 3 meds. Maybe a lower sodium diet, some regular walking. He may be just fine. I don't know if others have any other thoughts. Laura, Nicole.
Great point, Savitha. I like how she started the nifedipine, and I probably would have gone to 60 milligrams, but I agree that probably in another month, if he needs an escalation, because I think about 30 of nifedipine and 10 of amlodipine as similar, I would perhaps screen this person for aldorenin ratio and looking at it, at least keep in the very back of my mind renal artery stenosis, because it was pretty high and he is on 3 medications, but I don't think we see the full medication effect. So again, this is probably a less is more, and you've gotten him into the safe spot, and you probably don't want to relatively drop his blood pressure too much, because he might actually be symptomatic with normal blood pressures if he's been running that way a long time. With his next set of labs, I'd probably do a screening for the renin-aldo ratio, but I would also just hold the line on the therapy. Laura, what do you think?
I wasn't sure in this case, and that's why I did all this, because he came with such a high blood pressure and everything is so new. And I wasn't sure how long, I don't want him to have a stroke or a heart attack, but then how long is too long to wait? How long is, what should, so it's really good to get these, it's okay for him to be at this blood pressure for a few weeks.
This did not happen overnight. So,
No.
so I think you are actually already there, because you mentioned you were going to send him to a nephrologist, and I think you can wait it out. When
Yeah,
you've
I
gotten
kept
there-
him on the 3. I just changed the amlodipine to nifedipine, so he's still on 3, nifedipine 60, and then our nephrologist usually does all the testing, the further testing for the secondary.
You're
issues.
only 3 weeks in. He's down to 140/80. That's a success in my eyes. I probably would not have switched him. This is just me. I would not have switched him to nifedipine. Just let him be and maybe have him come back. But I'm not saying anything is right or wrong. It's just clinical practice. The point I want to make is that I think you're on the right track and you've done all the things. And I don't think he's unsafe. I think he's fine. And it'll probably just take a little bit of time, because the drugs need to reach steady state. It's 3 weeks. So I think you're good for now.
I'm just going to throw in the recommendation for the DASH diet is a very Mediterranean, really emphasizing whole foods, healthful fats and things like that. If he has access to a computer or a family member, there's a wealth of DASH diet materials at reading levels that are consistent for a lot of patient populations. I haven't checked recently to see if there's Spanish, but that's a really good suggestion. The blood pressure and the fatty liver as well, with both.
So the other comment I just wanted to make is about his severe hyperglycemia. His random was 298. He did have an A1C of 10. And I actually would have considered talking to him about insulin therapy, because I think he would have been fine. I agree with Savitha. I've seen people come from A1Cs of 10 just with metformin down to 7 in 3 months. But unless I see something specific in their diet, like they're drinking a lot of Gatorade or soda pop, I'm concerned about those sugars that are with an A1C above 10. And I would worry, especially in our COVID time, if he did have an illness, that his hyperglycemia could push him over into the edge and he could develop DKA, ketosis. So I may have been talking to him about insulin. I want us all to keep it in the back of our minds. You're seeing him quite frequently, but I would consider an initiation of basal insulin in this patient versus using a GLP-1 receptor agonist, which is what the ADA recommends as the first injectable, as long as there isn't evidence of severe hyperglycemia.
I partly agree with Nicole, and this is where we don't always see eye to eye. I agree with what you did with the metformin. I think that's completely appropriate because you have regular follow-up. And this is somebody who's just walking in, has no symptoms. That's why I asked you, does he have symptomatic hyperglycemia? He doesn't. So I think I would have done exactly what you did. I probably would not have brought up insulin. But again, styles vary, and that is okay, is the point I want to make here. quickly on the mild hypertriglyceridemia, when you have severe hyperglycemia or newly diagnosed diabetes, elevation in triglyceride is common.
Yeah.
But you also said it's a non-fasting lipid panel. So non-fasting state, that's actually not a bad non-fasting triglyceride. So I would not touch it right now. You can just repeat it. I think adding the atorvastatin is appropriate. The HDL cholesterol is a little bit low. You can get a low HDL when the triglycerides go up, but that low HDL of 30 is a little bit lower than what you see when there's a higher triglyceride level. So he may have a separate genetic low HDL. The only thing that can raise that is regular aerobic activity. And the triglycerides will maybe improve. You want to check it non-fasting to see where he's at if you prefer. And with improvement in glycemic control, the triglycerides will get better. That's pretty much, the rest is all the transaminitis. The one thing I want to mention on the transaminitis is also that's very common in newly diagnosed diabetes. And as Dr. Landis mentioned, lots of times it's because this gentleman has had uncontrolled diabetes for a while. I would suspect he probably maybe has a mild hyperlipidemia, possibly. It's hard to know. Mild hypertriglyceridemia especially can raise ALT. So when you start statins, treat the diabetes, that transaminitis will come down. Just like Dr. Landis said, I would not be in any hurry to send him to a hepatologist yet, but just initiate all these things that you already did and then just follow him. I just want to show you this. Dr. Landis did not have this reference, but this is a really nice article which has a nice schematic on and how to work through elevated LFTs, what to do with the treatment of metabolic fatty liver disease. It's all in there. So I won't go over this, but weight loss is a big part of this. His BMI is 36. Again, as was said, it's a marathon. It's a law. This is a chronic illness like none other. You need to get buy-in from him, educate him, build up his knowledge base, and then hopefully he'll stay engaged and he'll be successful in managing. I'll stop with that. I'm happy to take questions, thoughts, critiques.
Thank you, Savitha. Would you mind putting back up that grade 8? That's one thing we want to highlight for the Department of Health. I love this case because it basically highlights every metabolic disease out there, it seems like, with hyperlipidemia, hypertension, diabetes, weight. And the Department of Health is actually asking us to have our patients advocate to discuss these things using this grade 8 standpoint. And there's a little QR code that you can scan. What's great about the website is this reminder also is in many different languages. So it's not just Spanish and English. There's 15 different languages that you can use it as a talking tool for your patients. So just wanted to highlight this as we are doing the cardiometabolic echo. But I will say this ends session 10.